who have joined. We are very honored and privileged today to be blessed by the presence of Dr. Fairooz, who will be speaking on ocular tumors. I will give a brief introduction about her. Today's moderator will be Dr. Vikas, Khetan, who will be joining us shortly at the end. Dr. Fairooz is the director of Horus Specialty Eye Care in Bangalore. She established a specialty eye care for oculoplasty and ocular oncology especially. She is a consultant at Prabha Eye Hospital, Bangalore, Amardeep Eye Care at Trivandrum, Sushruth Eye Hospital in Mysore, and she heads the retinoblastoma services in Guangdong in China. She has done her fellowship at LV Prasad Eye Institute and Wills Eye Hospital, Philadelphia in USA. There are very few Indians like her who have so many awards, international awards especially. And to name a few, she has the American Academy of Ophthalmology International Achievement Award to her credit. She has the Asia Pacific Academy of Ophthalmology Achievement Award. She got the best scientific paper from American Academy in 2011, 14 and 15. That is a very rare feat. She has got the best poster award from American Academy in 2016 and 17. She got the best of show award for American Academy in 2013. And she got the best paper for Ocular Oncology in AIUS in 2015. She has been speaker at various regional, national and international meetings and symposium. Her areas of interest are retinoblastoma, orbital, eyelid tumors and conjunctival tumors. Parts of an international charitable surgical teaching mission for the past many years. She is a part of the international charitable surgical teaching mission, and she has a deep passion for teaching, and we are very, very grateful to her for having accepted our invitation today for this program. She is also a scientific member of the scientific committee of All India Ophthalmic Society. And I remember when we were campaigning together, she had a very unique style of campaigning, and obviously she had to win. She won, and she's one of the most popular persons in All India Ophthalmological Society. A very warm welcome to you, Dr. Fairooz, and thank you so much for being with us. I'd like you to begin your presentation on ocular trauma, please. Tumors, please.
Orbital tumors. Thank you so much, Dr. Sinha. It's a pleasure and it's an honor and privilege to be here. Thank you for your kind invitation and all the kind words and introduction. So this is something that I really like, teaching the postgraduates, and I'm really looking forward to it. Hope to keep it interactive as well. I'm going to share my slide now.
Yes, please.
Okay. Is it visible?
Yes, but you can make it full screen.
I'll do that. Now?
Perfect.
All right. Yeah. So, hi everyone and good evening. How many students do we have now?
We have right now about 15-20 people, but they'll go on adding by the minute.
Okay, perfect.
There are views on YouTube more than on this program.
Okay, no problem. All right, so today I'm going to take you through the tumors of the orbit. I have named it as a postgraduate online teaching program because we will go according to it'll be more of an exam oriented thing and more of a clinical description so as to know how each presentation in the orbit that you come across in your clinics. I'm Dr. Fairooz and Dr. Sinha has already introduced me. Thank you for the kind words. So, whenever we talk about an orbit, all right, so we call it as a Pandora's box. So for a clinician, for a student, of course, who's not exposed much to the orbit, a Pandora's box is always overwhelming and worrisome. So this is exactly, you feel worried that if at all I open the orbit, what am I going to see and how am I going to evaluate? What would be the diagnosis and how are we going to manage it? But then for an orbit and oculoplastic surgeon, I'm sure all of us, we have Ankit here, and many of us, orbit really fascinates us. It's so curious to know what comes out of the orbit. And of course, we get a lot of surprises in the orbit, but these surprises can be minimized. It is possible because anything is possible in the orbit. So a very meticulous clinical evaluation is so very important in these orbital lesions, be it neoplastic. We are talking more about orbital tumors today, be it neoplastic, be it inflammatory, infective. A thorough clinical evaluation can actually help you clinch the diagnosis. And of course, imaging plays a major role, be it CT, computerized tomography, or magnetic resonance imaging, MRI. Systemic evaluation is very, very important because be it a neoplasm or to differentiate a neoplasm from an inflammation or an infection, it is so very important to systemically evaluate the patient because there will be so many clues that will be lying hidden inside the body of the patient which will correlate to the case. So systemic evaluation is very, very important. Again, of course, appropriate management. Now, since it's a postgraduate teaching program, I thought I'll start with a little bit of anatomy of orbit. And if all of you are aware, I'm sure Ankit is aware, my first presentation during my post-graduation was anatomy of orbit. And I also got an essay for the anatomy of orbit. So anatomy of orbit is very, very important as a postgraduate student. It will come for your exam. So I'm sure all of you know. Can someone tell me how many walls makes the orbital wall? Anyone want to speak?
Anyone can unmute themselves and talk.
Just tell your name and speak. Yeah, someone? Is it because you don't know or you are shy? How many bones makes the orbit? I have few more questions in the anatomy. If you answer it, please go through the slides. Yeah, tell me.
7 bones.
7 bones, yeah. So orbit is basically a very small compartment, okay, which is made up of 7 bones. And what is the volume of the orbit? There's a question.
30 ml.
30 ml. And what is the volume of the eyeball?
5 ml.
6 ml.
7
Yeah.
ml.
7 ml. So textbook says 7 ml. So let us take it as 7 ml. So out of 30 ml in the orbit, a very small compartment, eyeball comprises only of 7 ml. So what are the rest of the structures in the orbit? So you have many other soft tissues, you have neural structures, you have vascular structures, which comprises of this very small compartment. And all these tumors and inflammation arises from this in the orbit. All right, so we have these 4 walls of the orbit. I'm not going to go into the detail of it. You should be remembering it, the medial wall, the floor, the lateral wall, and the roof. So as far as diagnosis is concerned, as far as management is concerned, the relation to the orbital anatomy, the relation to the orbital wall is very, very important, and you should be knowing about it. All right. Now, orbital apex anatomy. It is yet another short note or essay note for you. I'm sure all of you knows about this. We have the optic canal, we have the superior orbital fissure, and we have the inferior orbital fissure over there. So as far as the presentation concerns, if it is an apical lesion, it presents in certain ways where all these nerves, which is involving the superior orbital fissure, you'll have symptoms and signs related to these nerves, these vessels. There can be thrombosis of the vessels. So everything and anything has to be correlated to the anatomy, what is there in the orbit. You elicit the signs, you elicit, the patient comes with the symptoms, you elicit the sign, and that's how you come to the diagnosis. I'm sure you all know this, the superior orbital fissure, the inferior orbital fissure, right? How it is divided into superior, middle, and inferior, right?
Yes, ma'am.
Perfect. All right. Now, the neural anatomy is also very important because most of the orbital tumors and inflammation, they can have neural origin. They can be neural origin tumors. It can be closely attached to the nerves. So you should be knowing about the sensory nerves, the motor nerves, everything in the orbit, and of course the ciliary ganglion, which is situated in the orbit. As far as surgery is concerned, again, anatomy is very, very important, especially for the blocks, especially for navigating inside the orbit. Again, a little bit of orbital neural anatomy is also very, very important to know about, because there are tumors which can arise from the nerve, something like a schwannoma. A schwannoma can arise from the infraorbital nerve. It can arise from the supratrochlear supraorbital nerve. It can even arise from the ciliary ganglion. So there are many things that you should be knowing about regarding the neural anatomy. Arterial anatomy is also very, very important. Venous anatomy is also quite very important. So this is a very simple way of representing the arterial anatomy, because they can be vascular lesions in the orbit, they can be arteriovenous malformation, they can be arteriovenous fistulas. All these things can be, and you should be very, very you should be aware of the fact that these vessels have communication with cavernous sinus, they have communication and anastomotic vessels, which actually connects the orbital vessels with the intracranial vessels. So it's very, very important and crucial. So origin of the orbital tumors can arise from all these structures in the orbit. It can be from the muscles, it can be from the mesenchyme, it can be from the apical tissues, it can be from the lacrimal gland, it can be from the inferior orbit, from the soft tissues. It can be arising from the sinuses, which actually encroaches into the orbit. So again, depending upon the origin, so whenever you write a short note, or whenever you even talk about anything, any topic for that matter in the Viva, you should be able to talk about its definition, what is an orbital tumor, and again classification. That is how the systematic way of going through any subject or any topic is. So depending upon the origin of orbital tumors, it is classified into primary, secondary, and metastatic. Primary is something which arises from the orbit itself. And as you all know, any tumors are classified into benign and malignant. Malignant, which is cancerous. So non-cancerous and cancerous. Secondary are those which arises from the adjacent structures. So what are the adjacent structure? It could be an eyelid. It can be like, the fornicial lesion extending into the orbit. It can be a large conjunctival tumor extending it through the, fornices, through the caruncle, and then reaching the orbit. It could be an intraocular tumor like a retinoblastoma, a melanoma, which can actually break, outside the confines of the eyeball, reach to the orbit. And also we have so many paranasal sinuses. We have the maxillary sinus, the frontal sinus, the sphenoid sinus, the ethmoid sinus, which is all around the orbit, where a tumor can arise and then come into the orbit. Metastatic, of course, which is rare, but it can still happen. So it is also said in literature that 25% of, malignancy, the first clinical sign arises in the orbit. That's when they come to an eye specialist, then you evaluate them, and then you get to know that there is some primary site of malignancy. So metastatic lesions can also happen in the orbit. Now, depending upon the tissue of origin, all right, as I told you before, it could be a neural tumor, it could be a vasculogenic tumor. Neural tumor, can someone give me an example? We'll go through the cases later. Someone? It's easy. It's an easy question.
Optic glioma.
Optic nerve glioma. Then?
Ophthalmology.
What is it? Not too clear.
Schwannoma.
Glioma to whole diya. Then what else? I got optic nerve glioma. Then 2. Second? Hello? No one?
Schwannoma.
Schwannoma, perfect. Then? Quick. Itna time. Anything else? Meningioma, right? Meningioma, neurofibroma, these are all the neural lesions. Now, vasculogenic lesions, again, we have many vasculogenic lesions. It could be a capillary hemangioma, it could be a cavernous hemangioma, and I will take you through the newest classification of vascular anomalies in the orbit later. Okay, mesenchymal soft tissue tumors, lymphoproliferative, lacrimal gland, histiocytic, bone-related and cartilage-related. Bone-related and cartilage-related is a little less common than the others. Do we have cartilage in the orbit? Yes or no? Anyone? Pin drop silence. Is everyone muted? Do we have cartilage in the orbit? Yes or no? I just need yes or no. I'll give you the answer.
Yes.
Where?
Trochlea.
Trochlea, yeah. So we have the only cartilage in the orbit is trochlea. Okay, so tumors arising from the cartilage in the orbit is quite rare. All right, yeah. So now again, another important thing that you need to know is about the spaces in the orbit. Again, when you classify an orbital tumor, you classify depending upon in which space they are. So you have this black asterisk over here. This is the intraconal space, the space inside the muscles surrounding the optic nerve. The space outside the extraocular muscles is the extraconal space. All right. And well, so these are the anatomical structures which is related to the intraconal space and the extraconal space. So I'm just going to give you the list. So the intraconal tumors are mainly, most commonly, and cavernous hemangiomas, of course, any oculoplastic surgeon or an orbital surgeon would actually agree that cavernous hemangioma is the most common orbital tumor that we come across. Then we have optic nerve glioma. So all the vessels and the nerves are situated in the intraconal space, and anything that arises from these vessels and nerves are in the intraconal space. Simple as that. Cavernous hemangioma, optic nerve glioma, meningioma, schwannoma, solitary fibrous tumor, or any intraocular extension of a tumor, like as I told you, retinoblastoma or a melanoma. Now, extraconal lesions. Extraconal lesions are lymphoma. Lymphoma, of course, is the most common malignancy that we see in the adults in the orbit. Schwannoma can be intraconal or extraconal. Extraconal how? If it is arising from the supraorbital nerve, infraorbital nerve, supratrochlear nerve, then it can be an extraconal schwannoma. Lacrimal gland, of course, it's extraconal. So any tumors of the lacrimal gland will be extraconal. Dermoid cyst, leukemia, sarcoma, metastasis, rhabdomyosarcoma, these are all extraconal. Now, there are certain lesions which can be both extraconal and intraconal, like lymphangioma, varix, lymphoma, sarcoidosis. So these are basically the classification of orbital tumors. If at all you get a question for your examination to write down, this is how the classification has to go down, and then you're complete. All right, now we go on to the case scenario. So this is going to be more interesting for you. Now, this is a 1-year-old girl. Okay, her parent went to an ophthalmologist telling that they have noticed squinting. And of course, the ophthalmologist agreed to the fact that there is squinting. And then they said, you might observe it. But then the mother has also noticed there is some kind of bulginess, which is very, very minimally increasing as the days pass by in the left eye. As you can see here, she has an esotropia, and there is some amount of bulginess in the eye as well. There is something else that actually you can see in the facial, in the external picture over here. Eyes looks fine. This periocular area looks fine. This is okay. And there is some amount of pigmentation that I can see over here. Can you see that? Pigmentation over here. Then the systemic evaluation, as you can see over here, also has pigmentation. So a child, a 1-year-old child presenting with a proptosis with all these pigmentation, what could these pigmentation be? Easy answer. What are these? How do you want to correlate this?
Neurofibromatosis.
Neurofibromatosis. The presence of Caféole spots. Caféole spots? Right? Who
Yes,
said ash leaf macule? Someone said that?
Yes, ma'am.
Okay, where is ash leaf macule seen?
Over the back.
No. In which disease? In neurofibromatosis, you see that?
Tuberous sclerosis.
Tuberous sclerosis. All right, yeah. So ash leaf macules are seen in tuberous sclerosis. So this is very classical of neurofibromatosis. Neurofibromatosis again can be a short note for you. You should know the classification, everything. You know what are the diagnostic criteria of neurofibromatosis is also very, very important. So usually children present. So optic nerve glioma is a tumor, an orbital tumor that you see in childhood, and this is exactly how the patient presented with. So how do we evaluate? Mostly if it's a neural lesion, we prefer an MRI over CT, but other than neural lesion, anything in the orbit, we prefer CT scan because the bony outline is very, very important for an orbital surgeon. We want to know how the bone is, whether there is erosion, any changes in the bone, whether there is any, invasion from the opposite paranasal sinus. So CT scan is preferred, but if it is a neural lesion, it's always MRI. And this is an MRI showing an axial section and a coronal section. So what do you see here? A large thickened optic nerve. So optic nerve is still here, that is the apex, but it is extending even up to the chiasm in the left eye. All right. Another thing that we noticed was even in the left eye, the proximal optic nerve is thickened. In fact, she had severe optic disc edema. I don't have the picture of the fundus in the left eye, and she had a mild hyperemia in the right eye. So at this point of time, you know that she's going to go blind in the left eye because you see the optic nerve, how thickened it is when compared to the other eye. This eye also has a little bit of thickening. So you want to save the right eye vision as much as possible. Stop the progression of this tumor over the chiasm and then into the intracranial space. All right. So this is what you see here. That is the optic nerve that you see in the MRI, and this is a thickened optic nerve in the left eye. So these are the muscles that you see in the MRIs: the superior rectus, the lateral rectus, the medial rectus, the inferior rectus. Intraconally, you see the optic nerve. Okay, and then you compare the optic nerve of either side. So this was a case of optic nerve glioma. Okay, so the importance of the fundus evaluation. Fundus evaluation holds a very prime importance in any orbital lesions. Okay, one, there could be a compressive optic neuropathy due to this orbital lesion. So the color vision to start with, the pupil to look for the relative efferent pupillary defect, and detailed fundus evaluation of the optic disc is very, very important. This child, of course, had what I said earlier. So this is, I've already given you the diagnosis here. So this is an astrocytic hamartoma. So any child with neurofibromatosis can have an association with retinal astrocytic hamartoma. So this has to be kept in mind, apart from the optic disc edema and optic atrophy that you would look for. Another thing that is associated with neurofibromatosis in the optic, in the fundus evaluation, is retina combined hamartoma. So always evaluate. If you get a patient even with an plexiform neurofibroma of the eyelid without any orbital extent, always dilate these patients and look for these lesions in the fundus. Now we are going on to the next case. So you saw how an optic nerve glioma presents in a child. Now a 1-year-old boy, same age, bulging of the eyeball, deviated eyeball again with rapid progression. So as you can see here in the left eye, we call this, more than proptosis, we call this, of course there is proptosis, we also call it as dystopia, whenever there is deviation of the eyeball along with proptosis in various directions. So this is actually, an eye is dystopic superiorly. So that means there is something sitting inferiorly, all right? And of course there is a proptosis. So the parent says there has been a rapid progression in the proptosis and they are worried about it. So imaging. In this case, we do CT imaging because we are suspecting something inside the orbit. And this is what I see in the CT. So here again, when you, all of you should be able to read a CT scan, you should actually know what axis it is. So this is a axial cut. Okay, so you can have an axial cut, you can have a coronal cut, and you can have a sagittal cut. So this is very, very important. And when you say or explain a CT during your examination, you have to say this is an axial cut. If you can say that it's an inferior cut, a middle cut, or a superior cut. So this is an inferior cut. Why? Because you can see the nose here, the nostrils. All right, and so this is a well-defined lesion over here, which has multiple cystic spaces. It is heterogeneous, okay? It doesn't look the same. Somewhere it is solid, somewhere it is cystic, and in one place, as you can see here, there is hyperdense lesion. So this area is very, very hyperdense, and it is as equal as the bony outline over here. You can see here. So anything which actually, is similar to the bone, what would you suspect in the orbit? If it is a similar density of the bone, what could it be? Of course, it can be bone. Anything else?
Calcification.
Calcification. All right. So there is calcification, there is heterogeneity, there is cystic space, there is solid space over here, and it's very, quite well defined lesion. So this is the coronal cut over here. Okay. So as you can see here, the tumor extends, almost from medial to lateral orbit, and this is the extent. So what did we do? So all these orbital tumors, whether it's benign or malignant, surgery plays a definitive role. It could be a diagnostic it could be a diagnostic biopsy, or it could be a therapeutic biopsy also. So it's a very well defined lesion, be it benign or malignant. We often go inside and take it out in toto. That's exactly what we did in this case. We did not suspect any malignancy in this particular case. A child with a cystic lesion, which is very heterogeneous, this is exactly what we suspect clinically. A teratoma. And pathologically, this was proven to be a benign teratoma. Teratoma can be malignant also. So what was the calcified area? Was the teratomatous bony portion of this teratoma. As you can see here, this is the bony area over here. This is the fleshy area over here. This is the cystic area. And this, impression that you have here is the tumor which has been actually compressing the optic nerve inferiorly and medially. So this was a large tumor which was excised with a very minimal keyhole approach through the inferior pharyngeal conjunctiva. So there are various approaches in the orbit again. I will be covering the surgery, everything together. So this is an inferior pharyngeal approach. So any inferior tumor, a little bit of infralateral tumors and medial tumors, we usually approach through the inferior pharyngeal approach because it's quite scarless and very good exposure in fact. All right, so this was the extent. So this was the case with orbit teratoma, which was surgically excised. And this was the optic nerve glioma, where you actually want to stop the progression of the, the larger lesion, which is in the left eye, and also save the vision in the right eye. That is the aim. So this child, clinically and radiologically, the diagnosis was made, no biopsy was done, and she was started on systemic chemotherapy. And this is after 1 year of systemic chemotherapy with the disease well under control. All right. Now, there are situations where, there's a very small child where the parent says that the eye has been swollen, right after the birth, and this is what it is. So you see a cystic lesion over here, a bluish tinge over here, and as you can see, water is actually aspirated through a syringe from the lesion. Anyone want to give the diagnosis here? Whoever answers the maximum will be getting a prize at the end. What is this? Anyone? These are quiz questions, by the way. So what do you see here? A microphthalmic eye?
Eyeball.
Yeah, right? And a cyst.
Cystic eyeball.
Sorry? Cystic
It's
eyeball?
a cystic eyeball.
Cystic eyeball will not have microphthalmia.
Lymphangioma?
Well, the differential diagnosis. Lymphangioma, you will get an aspirate like this, but what about this lymphangioma? Usually the eyeball is normal, right? They have good vision, the eyeball is normal. Okay, I'm going to give you the answer here. It's a colobomatous orbital cyst, okay, which is usually congenital. And this is how you treat it. And well, cosmetically, you kind of take care of the socket as well with artificial eye or implant. Now, this is what, who said cystic eyeball? Name? हेलो सिस्टिक आईबॉल किसने आंसर दिया मुझे? No one. You'll get a prize. Tell me thing.
No, Fairooz, I am Dr. Pammi here.
Oh, okay. All right.
I am an ex-assistant fellow of oculoplasty.
All right. Okay, no problem. All right. So this is what cystic eyeball is. Okay, so the entire eyeball is basically a cyst. It's a malformed eyeball and it is cystic. So this is a congenital cystic eyeball. Now, well, going on to the, so cyst in childhood, you saw adults can also have cyst, which is quite common, like, one of the common orbital tumor. There's a 20-year-old gentleman with the bulging of the eyeball, as you can see here in the right. And this is the CT scan image. You can see Again, a very well-defined lesion. So this is the lateral rectus that you see over here. It is pushing the lateral rectus medially, all right, and very well-defined. And you have the clue over here. So this is the lateral wall, the zygoma, right? Yeah, and there is an extension. There is a sequestration of the same lesion into the temporal fossa through the lateral orbital wall. No visual complaints in this patient. Okay, so what could it be? A dermoid cyst. So this is a deep dermoid cyst. So adults can also have cyst, a neoplastic cyst inside the orbit. Dermoid cyst is one among them. And you all know it's basically the sequestration of the embryonic epithelium during the development along the suture line. So it can be in the lateral orbit. It can even be in the supromedial orbit. And the cyst can cause inflammation. Inflammation can be the primary presentation in this case, where the patient can present with pain and swelling if at all it ruptures. Then it will mimic an orbital cellulitis. Finally, after the imaging, you'll get to know that there is a cyst inside. So most commonly, children present with an anterior dermoid cyst. So this is how the common presentation is. In the supralateral portion, you'll get the small swelling in a child. Most of the time, it will be mobile. So whenever clinically it is immobile and attached to the underlying bone, it's very, very important to image these patients in order to see whether there is any extension. So this is basically a case of dumbbell dermoid. We call it a dumbbell dermoid. In a dumbbell shape from one compartment, it is extending into the other compartment. So that is about the cystic lesions. Now we are done with it. This is a very interesting case, a 10-year-old girl presenting with proptosis, diplopia, and a rapid progression. So when she came in, we thought it could be a case of an orbital cellulitis. It could be, infection, because it was just 8 days of complaint that the baby had. And we asked her whether you have pain. No, not much of pain, very mild discomfort in the eye. So orbital cellulitis is kind of ruled out. Do you have fever? She says, no, I didn't have any history of fever. So although, we thought probably it could be an abscess, which is not too painful, we went ahead, looking the anterior segment, checking out all the muscles, and we saw a lot of subconjunctival hemorrhage. And this is basically she has been rubbing her eyes and these dilated feeder vessels just broke out. So that means there is dilated feeder vessel and there is something, it could be a severe inflammation or something growing inside. So we took a CT scan over here. All right, and this is what we found in the lateral orbit. So initially when I saw, I thought probably, there is some kind of a pocket over here. It could be a lateral rectus abscess. It could be an abscess sitting inside the orbit. But then my eyes also went to this portion. So basically it is a lesion involving the orbit. It's involving the it is extending into the intracranial extension into the brain over here in the middle cranial fossa, temporal extension. And when you compare the bones of the right eye and the left eye, there is some amount of thickening. We call it hypersclerosis. And there is also, as you can see here in the coronal, there is erosion of the bone, a lesion which is extending into the brain, sitting inside the orbit, affecting the bone. So any lesion inside the orbit, whenever we find bony erosion, something that we really have in mind is malignancy. Second thing, in a tuberculosis endemic area like India, we also consider tuberculosis as a other differential diagnosis. So we had, a diagnosis of tumor in this child, a malignancy in this child, orbital malignancy versus an inflammation. A neurosurgical opinion was sought, and so basically this is a triradiate lesion. So this is how I have been taught during my fellowship. So whenever you find a triradiate lesion, these are the things that we would keep in mind: neuroblastoma, PNET in children, sphenoid wing meningioma in adults, plasmacytoma in adults. It could be leukemia or lymphoma. So these are the malignancies. So this is what we thought about, and this came out to be an Ewing sarcoma, PNET. A bone marrow biopsy and PET scan was luckily within normal limits. She did not have any systemic metastasis. It was primarily in the orbit, and then she received chemotherapy and stereotactic radiotherapy. So in any malignancy in the orbit, we discuss the risks and benefits to the parents. So mostly these will involve a multimodal management, including chemotherapy as well as radiotherapy. All right. Now, another very common tumor in children, as you all know, you're all taught that the most common malignant tumor in childhood is rhabdomyosarcoma, and this is how rhabdomyosarcoma would present. It will be very reddish. The child will again have, history of, there will be a growth which is growing within 10 days, within a week, very rapid progression. You'll see all these dilated vessels. They can be, hyperemia, chemosis in the conjunctiva, and this was a case of rhabdomyosarcoma. So it's important because you should know that it's the most common primary orbital malignancy. So what we do is like we go and excise as much as possible, but often not completely possible because there can be microscopic residual inside. And it's very important to know the international classification of rhabdomyosarcoma. Alveolar sarcoma is the most malignant among the others, which is embryonal and botryoid. And depending upon that, and depending upon the various involvement of the orbit, the paranasal sinus, distant metastasis, it is classified into low, intermediate, and high. And again, it is grouped. And depending upon the grouping, actually, you decide how the prognosis will be and how the further management will be. I'm not going into detail of this because I'm with the postgraduate students over here. Okay, it's just an overview for you. So again, there are current recommendations in the treatment of rhabdomyosarcoma. We give them chemotherapy and then again adjuvant radiotherapy in situations where it is required, as in stage 2 and stage 3 of rhabdomyosarcoma. Now, going on to other lesions in pediatric age group, 11-year-old boy who gives a history of a fall. He also, developed an eyelid swelling and eyeball. He was referred as a case of a retrobulbar hemorrhage. Of course, there is retrobulbar hemorrhage over here. All right, but then he looks a little bit, toxic. He's not looking healthy. He's looking tired. Of course, there is some amount of fullness in the contralateral eye also. There is a, kind of a swelling over the cheek, which is seen. So whenever a child presents with a proptosis, with ecchymosis, the first thing that we would think of and kind of want to rule out is leukemia. Okay, so something like a granulocytic sarcoma. So the one test that we would do, or the two tests that we would do, is like, of course, imaging is very, very important, which will actually let you know the, what is the extent of the tumor, whether the contralateral orbit, and in this case, of course, the contralateral orbit was involved. And the most important test in these cases in childhood proptosis would be a peripheral blood smear and a complete blood count. And peripheral blood smear in this child indicated granulocytic sarcoma, acute myeloid leukemia, and unfortunately this child is no more. This case has been reported in IGO. So this has to be ruled out. So again, ecchymotic lesions, proptosis in children. Metastatic neuroblastoma is something else that you should always rule out. And as I told you about the triradiate lesion, metastatic neuroblastoma also presents as a triradiate lesion. Now we are going on to the adult lesions. We are done with pediatric. 32-year-old lady, blurry vision and bulgy eyeball. So a very minimal bulge in the right, but she does have blurry vision in that eye. We did a CT scan over here and we can see a well-defined lesion. Again, it's kind of heterogeneous. You can find a little bit of necrosis in the center, which is sitting right there. And here it's pushing the optic nerve, medially and upwards. And this is how large the lesion was. She underwent surgery, and this was one of the emergency orbital surgery that we had to take up during the COVID period. And this was how the large lesion we got through. And this, even intraoperatively, it was looking more like a schwannoma. And again, histopathologically, it was confirmed. So these arise from the Schwann cells of the nerves, from the peripheral, sympathetic, and the cranial nerve. And this is how she looks like after, again, an inferior phonacial approach with a lateral canthotomy in her. And she looks absolutely fine after 3 months of surgery. Yet another case, so she came with proptosis that someone has noticed. If you look even closely, it's very, very difficult to identify the proptosis. But when you compare the superior sulcus, deepening compared to the left, the right is slightly full. So of course, the right eye has a very, very minimal proptosis. proptosis, but her vision was significantly reduced. Okay, she was almost like counting finger. And this is the clue to the diagnosis. A proptosis with an optociliary shunt, you often think of a meningioma. And this is a CT scan pictures. You can see thickening of the optic nerve over here. Okay, something arising from the optic nerve. And the classical picture in optic nerve meningioma is the tram track sign, which was found here. So this was a case of optic nerve sheath meningioma. So meningioma, again, yet another meningioma is there, which is called the sphenoid wing meningioma, which is totally different from optic nerve sheath meningioma. Sphenoid wing meningioma arises from the sphenoid bone, and it can extend into the orbit, into the temporal fossa, and intracranially. And this patient was also treated during the COVID times, and she received debulking followed by radiotherapy. All right, so going on to vascular tumors. So before going on to the vascular tumors, I just want to take you through the classification, the International Society for the Study of Vascular Anomalies. We have always been talking about hemangiomas, lymphangiomas, etc., but these are all reclassified and reframed now. So we have something called high flow and low flow vascular anomalies in the orbit. So high flow are arterial aneurysms, fistulas, AV malformation, and low flows are the venous. It can be distensible, it can be non-distensible. Distensibles are the varices, and non-distensible ones are simple cavernous hemangioma. All right, lymphatic, it's the lymphangioma. It could be microcystic, macrocystic, and even lymphangioma can be lymphatico-venous. So this is how we actually should be, rephrasing and reterming these common lesions. So 34-year-old gentleman who came for a regular eye checkup, he doesn't have any complaint, but the doctor noticed a proptosis, and there was no visual complaints. Again, he has a proptosis in the right eye over here, and as you can see here, there is something which is very silently sitting, very well defined intracorneal lesion, and this is exactly how cavernous hemangioma or the venous non-distensible lesion looks like, and this was how it was. So it's not always that cavernous hemangioma, I'm sorry, the picture is not here. So it's not that I had a picture of a patient who, who had, so cavernous hemangioma, if it is large, it can also cause visual compromise. So it has to be taken care. Now, a dangerous variety of cavernous hemangioma is there. You have to be very, very cautious of this kind, which actually sits in the apex, and this is called the pear-shaped cavernous hemangioma. So as an orbital surgeon and an oculoplastic surgeon, we would never go inside to operate these cases, because after going inside to get the tumor out, you might actually land up compromising the visual drastically, injuring the optic nerve. So gamma knife radiotherapy is the treatment of choice. 28-year-old gentleman with proptosis, which is gradually progressive, as you can see here in the left eye. He doesn't have any other complaint, and in MRI, this is what we found. There is some kind of an intracorneal as an extracorneal lesion which is extending anteriorly, and lots of cystic spaces over here. So this is how classically a veno-lymphatic malformation would present as, that is lympangioma. It could be macrocystic or microcystic, and this is a macrocystic lesion. So these patients can present with pain, acute proptosis whenever there is a bleeding or hemorrhage in this cystic spaces. So intralesional bleomycin, pingiamycin, and picibanil is the treatment of choice, and bleomycin is very much in practice now, and that is what I prefer, and this is how we treat it. So this was a lady who was actually referred from Calcutta, West Bengal, and she has, proptosis in the left eye. They couldn't find any orbital tumor, so it's like a lesion-less orbit, but then she has proptosis, and this is how she presented with. Closer look, she had these dilated episcleral vessels, and she says her eyes are always red. So what did we suspect with a proptosis and such congested eye? We suspected a AV fistula, an arteriovenous fistula. So this came out to be a low-flow keratico-cavernous fistula after digital subtraction angiography that we did to confirm the diagnosis. So usually along with the proptosis, these are the cases that you would want to look for thrill and bruit, and they can sometimes it can be painful. So the arteriovenous fistula or keratoconus fistula, we do have different types. This is for the postgraduates to note down: A, B, C, and D. A is like the high flow type, which is usually due to trauma, and the arterial supplies from the internal carotid artery. Then you can have the B, C, and D, depending upon how the dural branches are in communication with the internal carotid artery and the external carotid artery. And usually these are low flow. So the low flow fistulas will never give you a bruit or thrill, and still you should be suspecting it, and these patients should undergo appropriate diagnostic techniques. So these are the few separate and important or different imaging techniques that we would use in vascular lesion: a biphasic CT angiogram. If at all you are in doubt between an hemangioma which is sitting in the apex, and you really want to kind of get the diagnosis clinically and radiologically, MRI angiogram in other AV malformations, AV fistulas, and digital subtraction angiography in AV fistulas really help. So this is a case who has been referred to me as a case of blepharoptosis of the right eye. Of course, she has a blepharoptosis, and this has been, onset is like 3 to 4 months. So whenever we see a blepharoptosis in an old patient, we think about a few things. Most commonly, it's an aponeurotic acquired ptosis. So aponeurotic acquired ptosis usually have the lid crease higher. Here, as you can see here, there is more of a fullness and the lid crease is much lower. So obviously, it's not an aponeurotic ptosis. And ptosis, apart from ptosis, she has some kind of fullness in the upper lid, right? So what would I do? Well, I'm not convinced about blepharoptosis. I'm not going to take her for a ptosis surgery here. The first thing that I would do is to image her. I did image her. And in the CT scan, this is what I found in the superior orbit. Okay, this is the supromedial orbit. There is some lesion which is hiding inside, as I was kind of suspecting. So any lesion like this, in the orbit, kind of an inflammatory puffiness of the eyelid, lymphoma is something that you should always think about. Lymphoma was thought about in this case, and this is the superior oblique muscle over here, and it was wrapping around the superior oblique. This is a lid crease incision we took in order to approach the orbit, and this was the tissue which was taken out. And a lot of immunohistochemistry was done for her, because some were positive, some were negative, and finally we had to reach to this very rare lymphoma that arose from the orbit, and it was a T-cell lymphoma, which was a follicular helper phenotype. And unfortunately, she had so whenever a patient presents with who's diagnosed to have orbital lymphoma, a systemic evaluation is very important in order to rule out whether it is primarily the orbit, or whether it is secondarily affecting the orbit, or from the orbit whether there is any involvement of the other systems. So she had para-aortic lymph nodes, she had paratracheal lymph nodes, she had neck nodes, and bone marrow biopsy was also positive, but she responded well to chemotherapy. So a lymphoma can arise in the orbit in various forms. So this is a case, the left-hand side, where it's arising from the lacrimal gland, and this was a case with proptosis and bilateral muscle involvement with the lymphoma. Both of them received radiotherapy, and ocular adnexal lymphoma. Now, a 52-year-old lady with proptosis, gradually progressive vision loss, previous biopsy was done. She doesn't have the report from a village. Anything which is in this, you can see the previous biopsy scar over here. So anything which is in the suprolateral orbit, we would always think of a lacrimal gland lesion, all right? So she doesn't have pain, and she says it's gradually progressive. So we are not thinking in terms of a malignancy. Lacrimal gland malignancies are very lethal. We cannot take it like, we have easily, and it has to be really taken seriously. So since she doesn't have any much of a clinical symptom regarding malignancy, we thought of the benign lacrimal gland tumor, which is common as, what is the most common benign lacrimal gland tumor? Anyone? No one?
Adenoma.
Pleomorphic adenoma. Pleomorphic.
Pleomorphic adenoma, perfect. So that's what, I thought about. It could be a pleomorphic adenoma. And this was how big the lesion was. The lacrimal gland could not be identified separately. A very well-defined lesion. Bony outline is perfectly fine. Although clinically she presents with, benign symptoms, you should still want to see how the orbit looks like, the bony outline. It looked very, very benign. But this turned out to be a solitary fibrous tumor. Okay, solitary fibrous tumor, hemangiopericytoma, is kind of not a new variant. We do, of course, see it in the orbit, but these currently has been put in one spectrum, the fibrous spectrum of on one side and the cellular spectrum on the other side, which is hemangiopericytoma, and it can turn malignant. So solitary fibrous tumor has to be excised totally. But if you don't excise totally, it can have massive recurrence and it can turn malignant. So this was a case of a solitary fibrous tumor. A 52-year-old, it is a gentleman with bulgy eyes in the left eye, recently noticed and came for a second opinion. In fact, he was, suspected to have a meningioma. As you can see here, what I showed you earlier is sphenoid wing meningioma, because you can see there is bony breach, the bony erosion, a lesion in the orbit, in the temporal fossa. And of course, even me, when the patient came for a second opinion, I also thought about a sphenoid wing meningioma. And this came out to be a lacrimal gland adenoid cystic carcinoma. And this was a huge surprise for me inside the orbit, because as you can see here, the proptosis is kind of very, very minimal. Superior temporal area of the orbit, you don't find any swelling, unlike any other lacrimal gland lesion. But this is something which is gone beyond the bone, the lateral wall, into the temporal fossa, and this is how it was. So this was definitely a Pandora's box in my practice, and this came out to be a lacrimal gland adenoid cystic carcinoma, which is a very lethal tumor. Now, these are the secondary tumors of the orbit. It is sebaceous gland carcinoma of the eyelid can extend into the orbit. A conjunctival squamous cell carcinoma can extend into the orbit, and even a CA maxilla can extend into the orbit. So orbit comprises of, indolent benign tumors. It can have lethal malignant tumors. There are certain inflammation, again, that can present as, orbital malignancy, or orbital malignancies, vice versa, presenting as inflammation. So as I told you, the most common malignant orbital tumor in adults is lymphoma, and most of the time they can present as orbital inflammatory disease. So any orbital inflammatory disease, you treat with steroids initially. If it recurs the second time, it is mandatory to go inside and take a biopsy, and make sure you stop the steroids, wait for 3 to 4 weeks, and then you go and take the biopsy, because then, you can have a misreporting of the histopathology in the presence of steroid. So not all orbital tumors presents as proptosis. There are orbital tumors that can present with enophthalmos also. Does someone want to tell me what are the orbital lesions that can present with enophthalmos? Anyone? No? Ankit? Pammi? No? All right.
Hello, can you hear me?
Yes, Bolo.
Hello?
Yes.
Any sclerosing lesion such as a metastatic breast cancer, or a lesion which is eroding the floor of the orbit can also result in some amount of enophthalmos.
Okay. Anything else? A benign lesion which can cause enophthalmos, and there is a test which will rule out. Just
Thyroid.
Huh?
Thyroid disease.
What is it?
Thyroid.
Thyroid? Thyroid is proptosis, no? A benign lesion. One simple test, if you do in the OPD, they present with enophthalmos, but they can have proptosis with that test.
Horner syndrome.
No. Valsalva.
Yes, Valsalva. What is the diagnosis?
It's means AV malformation.
No, it is a vascular lesion.
It's a vascular lesion.
Carotid cavernous fistula.
Carotico cavernous fistula. We already saw that, right? What is it? In ophthalmos.
Varix.
Varix, yes. All right, so varix. So when you try, this is after varicose. Yeah, so it just bulges off, and then you can see the proptosis happening here. And as Ankit rightly said, the serous carcinoma metastasis, most commonly in females, it could be from the breast. In males, it could even be from the gastrointestinal tract. So don't think that all lesions in the orbit will cause proptosis. They can have in ophthalmos in a very rare situation also. So this is something that I want to show you at the end of my presentation. This is the largest, analysis of orbital space occupying lesions, 2,480. And what they have found is that 8 most frequent orbital tumors in their series was dermoid cyst, followed by non-Hodgkin's lymphoma, cavernous hemangioma, mucocele, lymphangioma, sphenoid wing meningioma, optic nerve meningioma, and basal cell epithelioma. I think most of the things we had covered today here. And 68% were benign and 32% were malignant. So, the benign tumors was dermoid cyst, and malignant, what they found was non-Hodgkin's lymphoma. So these things you should be keeping in mind. So don't be scared of the Pandora's box. Don't be scared to open the box. It is important to open the box whenever you are in dilemma in an orbit. So biopsy is important. If it's a very diffuse lesion, you can go in and take an incision biopsy. A very good biopsy, a superficial, deep, and deepest portion of the lesion has to be representative areas of the lesion has to be taken. And if it's a very defined lesion, without you're sure that it may not injure the vital structures, total excision biopsy is mandated. And evidence-based management is very, very important in these malignant lesions because some are very, very lethal. It's important that we should improve the survival of patients, and newer advances in the management of orbital tumors have really given us better outcome. Thank you very much.
Thank you, Feroz.
Yeah, any questions? I'm willing to answer.
What is the most common benign malignant orbital tumor in adults?
Adults, it's lymphoma.
In children?
In children is rhabdomyosarcoma. Ankit, do you agree?
Yes, ma'am.
Okay. Any more questions?
Is lacrimal gland visible on CT and MRI?
Yes, lacrimal gland normally is visible, but not too big. It will not be that pronounced. But yes, you can find it in the superolateral orbit. But it will be, if there is any lesion, any inflammation or embolism, it is more constant visible. All the structures in the orbit will be seen in the imaging. So imaging and reading of the imaging is very important, as that's how we all are trained. Ankit would also agree that as an oculoplastic surgeon, orbital surgeon, we actually read our imaging. So we get a report from the radiologist. We never read that report. So we keep the CT scan, the CT scan, X-ray reading machine, and then we note down all the points, starting from the location, the shape, the size, adjacent structures, everything, and that's how we report our imaging.
Ma'am, different approaches to explore the orbit.
Yeah, so there are various approaches. As I mentioned in 2 of the cases that I showed, if it is inferior lesions, medial lesions, and infralateral lesions, the inferior pharyngeal approach with a lateral camptotomy and flipping back the pilot is a very good approach. Superior orbit, the lid crease incision is quite good, but whenever I feel that it's a malignant lesion, I wouldn't go through the lid crease. I would make an incision right over the lesion to have a direct approach, because malignancy, you can see the tumor through the lid crease if you're struggling to take out the tumor. So benign lesion, lid crease incision, absolutely fine in the superior orbit. But if it's a lacrimal gland adenoid cystic carcinoma or any carcinoma that you're suspecting, it's good to go probably over the tumor. It could be a subbrow approach most often. And yeah, so these are the approaches that I usually do in my practice. Any more questions?
So thank you very much, Fairooz.
Okay.
I think I should be getting the prize for attending the class. Not an orbital surgeon, but your listening to you was great. And like you said, Pandora's orbit is a Pandora's box, and many a times you'll be surprised by what you find.
Yes.
Not only when you're operating, but even histopathologically.
Yes.
So wonderful class. You covered most of the important topics in a very, very nice manner. Thank you so much for being a part of this series.
Thank you so much, Vikas. Thanks for the invitation. It's a pleasure always to teach. It actually energized me for the rest of the day.
And tomorrow we have Ankit. Ankit is present today. Tomorrow he'll be talking about the choroidal lesions, both benign and malignant.
Okay, I will be there, Ankit.
Thank you, Dr. Fairooz.
Yes.
So anything you want to say, Satyajit?
Thank you, Dr. Fairooz, for this wonderful presentation. I am pretty sure as soon as we have it up on the YouTube, it's going to go viral.
Thank you.
Such an amazing presentation.
Okay.
Thank you so much. I would like to thank Dr. Vikas Khetan also for being with us. And Dr. Ankit will be speaking tomorrow on choroidal tumor at 5 o'clock. He's here with us right now also, and we'll welcome him tomorrow formally. I would like to thank Intas Pharmaceuticals, Manish and Chandrasekhar for bringing this all together. And once again, thank you to all the postgraduates who had joined. A big, big, heartfelt thanks to Dr. Fairooz once again.
Thank you, Dr. Sinha, and congratulations to you, because many people are talking about this postgraduate program all over in India. So I'm sure this is like taking the postgraduate training to a different level. And congratulations for the initiative. And all the best.
Thank you, sir.
Yeah, before we go, the only thing I will add is that both Satyajit and Fairooz are in the All India committees. One is scientific committee member, the other is in ARC. So we now know that AIOS is in good hands.
Oh, thank you. Thank you. We will try our best, and we need more leaders coming up.
Yeah.